Hey, good afternoon, everyone. I think I know every single one of you in the room, but I'm Shannon Burke for, those who may not know me. I'm the manager of the Regional Cancer Program, Cancer Screening Prevention, Indigenous Cancer Program, and do a lot with the smoking cessation work at the DRCC. So thanks for being here today. We were so excited to welcome you to our first in-person ground rounds since before the pandemic. So exciting. Thanks for being here on a sunny Friday, Jeans Day for Charity Friday. Like, what could be better than in-person grand rounds on today? So thanks for coming. We have a very interesting presentation for you today. I've got Dr. Bill Evans here to speak. Dr. Evans is a medical oncologist. He has dedicated to his career to combining clinical practice focused largely on lung cancer with various administrative roles over his very distinguished career. He didn't ask me to say that, but I'm adding it. He led the development of lung cancer practice guidelines and the development of in Ontario, for many years, and he served on provincial and national health technology assessment committees evaluating new cancer drugs. Dr. Evans is currently the clinical advisor on smoking cessation at Ontario Health, Cancer Care Ontario, and he will be speaking to us today about the benefits of quitting smoking for cancer patients. So thank you all for coming, and without further ado, here's Dr. Evans.
Oh, thank you, Shannon, for the introduction, and thank you for attending. And I didn't know this is going to be the first of your in-person, so good on you. I missed the memo about jeans. I'm sorry. I now feel overdressed. But anyway, it's great to be here and to talk to you about something you already know a lot about, I'm sure. But I'm here, someone said, to kind of hype you up more about smoking cessation within the cancer environment. So it's helping our cancer patients to quit. So why should we try? When should we do it, and how to do it? So that's the real thrust of this. So I start off with your performance data. I'm sorry, it's not the best we've seen, but you had a good excuse, along with a few other centers in the province of Ontario. Implementing a new EMR is difficult, so Epic transformation, I guess, was epic in itself, and you're recovering from that. But and you exceed the provincial screening rate, so good on you for that. You've got a way to go to improve on your acceptance of a referral. So hopefully what I say today will be of some value and impetus to improve your performance on the acceptance of a referral. Because if the patient doesn't accept a referral, they're not likely to stop smoking. If they don't stop smoking, they won't harvest the benefits I'm going to talk about. So the objectives of this talk are to help you remember, understand why helping a newly diagnosed cancer patient to quit smoking is important and an important part of their cancer treatment. How tobacco, smoke, and nicotine can make cancer treatments less effective. This is really important to know and understand. When you should have conversations with your patients about smoking cessation, good times and bad times, and how best to talk to them, and what are the most effective approaches to smoking cessation. So by way of background, we're going to talk about tobacco as an addiction. Some people refer to it as a bad habit. It is not a habit. There are some habituating aspects, like the hand-to-mouth is a habit, but the actual smoking of tobacco is an addiction because of the nicotine. And we're going to talk about the benefits of quitting, the best practices, and some of the recent initiatives that have gone on in our province through Cancer Care Ontario, including the Tobacco Use Survey, the implementing of STOP, which your center has signed on to, and some lessons from the recent pilot in lung cancer screening. I always like to start with the reasons why people smoke. Understand that it's pleasurable. Within about 10 seconds of inhaling, the nicotine is absorbed into the bloodstream, goes to the brain, interacts with particular receptors that release dopamine in the pleasure areas of your brain, and you get a pleasant feeling. And once you've had it, you want to have it again. Unfortunately, that feeling of pleasure and relaxation and so on dissipates relatively quickly. That's why you have to take the next puff, the next cigarette. And that becomes a vicious cycle, constantly feeding the need to smoke. And most of the factors that get people smoking are environmental in nature. Maybe their parents smoked or their peer groups smoked when they were young and they got involved doing this. They thought it was just fun to do, pleasurable. And maybe they thought they could stop anytime. But that's unfortunately the catch here. It's not easy to stop. And there are personality traits, particularly amongst young men. I see mostly female faces looking at me, but young men tend to take more risks and to do some erratic things because their brains are slower to mature than ladies' brains. It's true. And adverse childhood experiences often are cause for people to smoke. And certainly stresses later in life are a reason to smoke again if you've been successful in stopping. It's important to notice also that at the top of the slide, there are some genetic factors here where even the onset of smoking or the number of cigarettes smoked per day and the ability to stop smoking can be determined by certain loci on certain genes. So it's not altogether an environmental issue. Now, nicotine alone providing pleasure maybe isn't such a terrible thing, but it's the 7,000 chemicals that are in cigarette smoke. It's hard to imagine that there's so many chemicals in cigarette smoke. 250 of them are noxious things like ammonia and hydrogen cyanide, just aren't good for your general health. But there are 69 different known carcinogens in tobacco smoke, 69 carcinogens. Some of the important ones are nitrosamines and polycyclic aromatic hydrocarbons. And smoking can affect literally every part of your body, from your eyes, the cataracts, to your toenails, and every body system in between. There's a potential adverse effect of cigarette smoking. And you can't read all the small detail there, but I did list it down the side, the different parts of the bodies for which harms can result because of exposure to tobacco smoke. So typically illness from smoking occurs several decades after the individual has started. And we all associate smoking with the risk of lung cancer, and it is raised by a factor about 25 times. It is dose related. The more you smoke and the longer you smoke, that sort of pack years amount influences the outcome of lung cancer, amongst other cancers. And there are 13 different cancers that are related to tobacco consumption, but also non-oncologic problems like your risk of heart attack and stroke. So, but an important point is if you can quit before the age of 40, the chances of death from a tobacco-related disease are reduced by approximately 90%. That's a huge decrease. But the problem is quitting's difficult. That's saying it gently. It is extremely difficult. And we used to say that people would try and quit 5 or 6 times. The studies now show that the person who finally is abstinent is generally made about 30 quit attempts before they've been successful. And the reason is the withdrawal symptoms, which come on very quickly within the first couple of days and peak, and then sort of gradually lessen over a week to 10 days. And so most of the relapses occur within the first 8 days or so. And as a result, people who try and quit on their own, only about 3 to 5% of them are successful. And then late relapses may occur even in those individuals when they experience a stressful event. And that's relevant to what we do in the Cancer Center, because receiving a diagnosis of cancer is a stressful event. So you might well ask the question, why bother screening for tobacco and use and smoking status with a low rate of quit? Well, the reality is, though, with proper and aggressive approaches to smoking cessation, 10 to 30% of people will be able to stop smoking, and that has benefits we're going to speak to. It can improve the various clinical outcomes of the treatments we give. And as patients are doing better now with our increasingly effective interventions, immune therapies, molecular targeted therapies, et cetera, patients are living much longer and indeed are cured. So we have the examples like in metastatic melanoma, where when I started and we tried to treat someone with metastatic melanoma, all we gave them was really toxicity. Now we give them the prospect of disease-free survival to 10 years and beyond and are probably cured. So now it becomes ever more important to help those individuals stop smoking so they don't incur another cancer or a non-oncologic problem, a heart attack, a stroke, chronic obstructive airways disease. So it becomes very important to think about this. So the evidence for the why is really important. It started effectively about 2014 with the US Surgeon General's report, which summarized about 400 studies in the literature on 500,000 patients and demonstrated convincingly that there was an increase in all-cause mortality, cancer-specific mortality, and the risk of increased primary cancers in individuals who smoked after a cancer diagnosis. And as well, there was fairly strong evidence, not quite as convincing, that there was an increased risk of recurrence, poor response to treatment, and increased treatment-related toxicity in those who continue to smoke. And this slide shows you some of the magnitude of the impacts on overall survival. 87% of 159 studies showed that there was a negative association between smoking and survival. And the estimate, the relative risk, was about 50% increase in mortality rate amongst those who were current smokers and somewhat less for former smokers. And you see that through the other important clinical outcomes down the left-hand side of the slide. And it isn't just affecting those individuals who have cancers that are associated with smoking, like lung and head and neck. It's across the board. So whether you have a hematologic malignancy, Hodgkin's, non-Hodgkin's, acute leukemia, breast cancer, gynecological malignancies, the red bars are saying that there's a negative association with smoking in the majority of the studies that have been done in those particular tumors. So the US Surgeon General also said in that 2014 report that if people quit smoking at the time of a cancer diagnosis, it would potentially reduce the risk of dying by 30 to 40%. I'd ask you, how many of our treatments in the cancer center reduce the risk of dying by 30 to 40%? Very few, very few. And so the idea has sort of been nurtured recently that we should consider smoking cessation as the fourth cancer treatment after surgery, radiation, and systemic therapies. But that's part of treatment. And that's a new way of thinking for the cancer centers and for all of us who work in cancer centers, that this is not just a nice to have, or maybe we should think about it. This is part of treatment. And to get the best results of our other treatments, which are also very expensive for the most part, we need to focus on smoking cessation as well. So how is it that smoke and nicotine can make the treatments less effective? Well, we've known for a long time in this situation of surgery, and it's not just cancer surgery, this applies to any surgery, that patients more commonly go back to the operating room, have worse 30-day perioperative mortality if they're a smoker versus a non-smoker. And probably a lot of it has to do with just inflammation in the airway from the tobacco smoke, the risk of pulmonary infections. But it's more than that, because the nicotine in tobacco smoke also affects blood vessels. So you get vasoconstriction. It impairs the inflammatory response and the ability of tissues to heal by interfering how fibroblasts lay down collagen for wound healing. So there's a greater risk of wound and pulmonary infections, greater risk of wound dehiscence and delayed healing and the development of hernias in patients who are undergoing surgery, which is all part of the rationale of why we should try to make sure our surgical patients, be they cancer patients or having their hips replaced, should stop smoking well before the time of surgery. As far as radiation is concerned, radiation works best when the oxygen tissue levels are normal. And when you smoke, you get a lower oxygen tension in the tissues you're radiating. And as a result, you get less response and worse survival. And the most dramatic example was a Canadian study done by the National Cancer Institute of Canada Clinical Trials Group, led by Dr. George Broman. It was in head and neck cancer. Look at the differences between people who didn't stop smoking and went through the radiotherapy for their head and neck. They got a complete response of 45%. The patients who quit or didn't smoke, 74% complete response. Huge difference. And look at the 2-year survival, 39% for the smokers versus 66% for those who stopped smoking. And this has been confirmed by other studies by the Radiation Therapy Oncology Group in the US. And you see that in this slide. So on the left-hand panel, you see the difference in survival between those who have stopped smoking versus those who continue to smoke. And then the right-hand panel shows you a curve in between those two. And that is for the people who just stopped at the time of their cancer diagnosis. So they had an improved survival, not as good as those who were never smokers or had stopped for a substantial period of time before the radiotherapy, but nonetheless an improvement. So you can see how it impacts the outcomes. Now, as a medical oncologist, I'm a bit embarrassed to say that we haven't done a very good job of looking at the effects of smoking on the cancer drugs we use. But down the left-hand side of the slide, you see a list of 7 different drugs that we commonly use in different cancers. Some of them are molecular targeted drugs like gefitinib and erlotinib, and some are standard chemotherapy drugs like gemcitabine and irinotecan, docetaxel. These drugs, for the most part, are metabolized by the liver's enzymes, the P450 enzymes, and you see in that second column from the left, they have funny names, CYP3A4 and so on and so forth. But the bottom line is that these enzymes are induced by tobacco smoke. So they're turned on more, and therefore they metabolize the drugs that we put into the patient's system more quickly. So it's cleared from the system and therefore has less biological effect. We see it with irinotecan. You don't get the same degree of neutropenia in a smoker that you get in someone who doesn't smoke. And presumably you probably get less anti-tumor effect. We see that clearly with erlotinib in lung cancer, where the response rates are half in the smokers versus people who don't smoke. So why would we prescribe an expensive drug to someone when they continue to smoke and you get half the benefit and a worse survival outcome? And this probably is a class effect, in my view, to all the what we call tyrosine kinase inhibitors. There's some other mechanisms as well. Smoking induces acute phase reactants in the blood, and they can bind to the taxanes, docetaxel, paclitaxel, making them less available for anti-tumor effect. So you've seen across all of 4 therapies that tobacco smoke or nicotine can change the effectiveness of the treatments we give. Nicotine also stimulates a number of biological pathways within cancers to change their phenotype and to make them biologically more aggressive, more resistant to apoptosis. So you really need to take this very seriously. But when are we going to talk to our patients about smoking cessation? Well, many people think that the diagnosis of cancer is a teachable moment when people are motivated to try and make behavioral changes that will give them the best outcome, the best chance of surviving their cancer. And when we do that, we need to try and explain what I've just explained in very simple language, really that quitting smoking is one of the best things you can do to get the best treatment outcomes and the least toxicity. And the question is, when should you talk about this with your patient? Well, I'll show you some data in a moment where patients themselves seem to say that at the first visit. But we all know, as those of us who practice in the clinic, there are a lot of patients who are kind of overwhelmed with all the information they received at that first consultation. The fact they have cancer, the type of cancer, the tests that may have to be done, blood work and so on, other imaging studies. And they may just be like a deer in the headlights. It's just too much. And then you're going to ask them to stop smoking as well. It just can be too much. So we have to have our antenna up and be sensitive to the individual patient's need. When is it right to have a fulsome conversation about smoking cessation? It may be quite appropriate at that first visit to raise it and say, this may not be the moment, but I'm going to talk to you next visit a bit more about why this is important. You have to just be sensitive to that patient's need. And importantly, and the word I often say in my talks, the one word I want you to take away from this talk is the word empathy. Empathy. We have to communicate with our patients who are addicted to smoking tobacco in an empathetic way. These are people who have already experienced a lot of stigmatization because the number of smokers around today is much fewer. And when you see a smoker, maybe you look at them a little weird as you walk by them, and they feel that. They know that. And they don't need you telling them in a sort of terse voice that it's not a good thing to be smoking when you've got a cancer diagnosis. They need to feel that you're supportive, caring, and empathetic to their situation. So just in terms of a cancer diagnosis being a teachable moment and being effective, there's an interesting study. It was actually a cancer prevention study where a large cohort of individuals were followed from 1990 up until over a decade. And during that time, they looked at the 2-year quit rate in those individuals who were tobacco users and got a diagnosis of cancer during that interval. And 30%, over 30% quit smoking, whereas only 19% of those who did not get a cancer diagnosis quit smoking. At 4 years, the percentage is 43% versus 34%. So that cancer diagnosis seems to motivate, and it becomes a teachable moment to influence the patient or help the patient to quit smoking. Another thing that's important is there's some myths around that I'd like to explode. One of them is it's too late to quit smoking once you already have cancer. The data I've already shown you tells you that if you continue to smoke, you'll have a worse outcome. So clearly that is a myth. It's not too late. But some would say, okay, they're incurable. They got metastatic disease, so it's a waste of time to try and do it then. My argument is, if you're going to treat them with radiotherapy, systemic therapy of any type, if you think they're well enough to take that, they're well enough to be helped to stop smoking, to make those therapies work more effectively, to get the best results for them. There's the myth that the time of diagnosis is not the right time to address smoking cessation, maybe for some patients, but I'll show you some data that contradicts that, that's close to home, and that cancer patients might not be interested in quitting smoking. Well, in terms of patient attitudes and preferences, this is data from the Princess Margaret Hospital collected by Dr. Lawson Ng and colleagues. 76% of patients felt a discussion of smoking cessation should occur at their first visit. Well, maybe that's not the biggest conversation to have, but their patients were prepared to hear about it then. And this is interesting. I don't know how many oncologists are in the room, but 88% of the patients who were on this study said they should be assessed by their oncologist rather than other members of the healthcare team. They want to hear it from their doctor that this is important. And I'll continue to make that point. In terms of readiness of cancer patients to quit, again, from Princess Margaret Hospital, 60% of new lung cancer patients who were currently smoking were very interested to make a quit attempt in the next month. And another 18% were somewhat interested. So the largest percentage of these lung cancer patients are prepared to try and quit if they're helped in the most appropriate ways. Head and neck cancer patients, it's even more so. 86% rather were interested in quitting smoking. So how do we talk to a newly diagnosed cancer patient? Well, first of all, we practice the 3 A's. So we ask, we advise, we act or refer. And in terms of asking, it's a fairly simple question. Do you use tobacco or do you smoke cigarettes, and have you in the last 6 months? And we would define a person who had smoked sometime in that interval to be a current smoker. Then we advise, and this is where I think oncologists just need to kind of memorize this so that it takes about 3 to 5 seconds to deliver, but it's basically quitting or reducing smoking, depending on the person's current state, is one of the best things you can do to get the best results from your cancer treatment and to have fewer side effects. Now, how long does it take to say that? But it's so reinforcing to the patient to have that message from the physician. And then nurses, social workers, other folks who are involved in providing care and providing the smoking cessation services have had that effect from the physician. And then finally act, and then it gets empathetic. I understand that quitting can be terribly difficult, or reducing can even be very, very difficult. And I'm going to refer you to someone who really knows how to do that. So that's an easy handoff. So you're not, as an oncologist or even a nurse within the cancer center, having to take on all the obligation of acting. And in the advising, really all patients, this is recommendations out of the U.S. Preventive Services Task Force, that all patients who smoke should be advised to stop as soon as possible, not just cancer patients, and then be treated with the most appropriate medications and provided with counseling. And again, that message about being empathetic. Now, unfortunately, oncologists don't seem to do this particularly well. They often ask about tobacco use. They even ask if the patient's willing to quit and advise them about quitting. But when it comes to discussing the medications or actually getting involved in the treatment of their patients with a pharmacotherapy or NRT, most don't. And so I don't push oncologists towards being actively involved in treating their patients with NRT and pharmacotherapy, or get involved in counseling. I think you have very busy jobs now. It's complex to deliver this therapy, and there's a lot of pressure, and there's backlogs as a result of COVID, et cetera. I think it's appropriate to hand off, but I do want that halo effect of the physician's white coat stethoscope and that imprinting onto the patient, that brief advice we mentioned just a moment ago, and then handing off to appropriate smoking cessation services and referring them to evidence-based approved medications and counseling within the cancer setting would be the ideal. And doing it and using the opt-out approach, which I presume is what you do here. We introduced that back in 2018 as the preferred way of handing patients off to smoking cessation services, rather than asking them, would you like to see someone about quitting? It's like, I am going to refer you to smoking cessation services because it is so difficult to quit. And there's good evidence that whether a person's ready or not ready to quit on what they tell you, you get similar impacts of making the referral to smoking cessation services. So even if they say they're not ready and you send them using an opt-out approach, you'll get as much benefit as those who say they are ready. And of course, patients still have the right to refuse if they are totally adamant against going to see someone about it. And what is the best treatment for smoking cessation or for smoking? Well, it's a combination of both nicotine replacement therapy or varenicline, or the combination of the two. I didn't say that quite correctly. You can get some people to stop with NRT alone. You get others who will find varenicline is equally good, and the combination seems to be better. And then there's combination NRT, which is the patch combined with short-acting NRT, which is to deal with the cravings that may occur. It's kind of like a breakthrough. So use of gum and lozenges or mist and inhalers can all be used to help the patient who is on the patch as well. And then bupropion has some effect. This slide's a bit busy, but I kind of put it up as much to commend an article by Peter Selby that appeared in the New England Journal just last year. It's a really detailed article on tobacco addiction, well worth the read, and goes into a lot of the subtleties about how to really do smoking cessation well, and a lot of the research is nicely summarized there. I'd also put it for another reason, because I get some pushback from oncologists who say that, we're so busy, treatments are complex, and oncologists get very good at managing complex treatment regimens. Well, how difficult is it really to prescribe varenicline? It's a 0.5 milligram once a day for 3 days, and 0.5 milligram twice a day for 4 days, and then a 0.5 milligram twice a day, or once a day for a few days, and then on to 1 milligram twice a day. It's not that complicated, nor is the patch all that complicated, but you do have to be aware that if the patient is heavily addicted, that is smoking more than 10 cigarettes a day, you start at a higher level, 21 milligrams. If they're not so heavily addicted, you would start at a lower level at 14 milligrams, and you decrease it over time. These things aren't that complicated, so I kind of reject the notion that it's too much complexity to add on top of managing the patient with complex chemotherapy or complex radiotherapy. just put this up, the different ways of dealing with the short-acting issues of craving and these available forms. But then you have to know a little bit about how to use them properly. For example, the gum isn't just to be chewed like you chew chiclets or something. You actually chew it to feel a tingling, and then you park it between your teeth and your buccal mucosa while it's being absorbed through the buccal mucosa. And when the tingling stops, then you chew it again till it tingles, and then you put it back, maybe on the other side, and park it there till the tingling stops. And that's how you get the effective use out of the nicotine. A lot of patients would, without any instruction, just go get it, chew it, doesn't work because they were never told how to use it properly. So these subtle little things are important, and some of those are included in Peter Selby's article. And then counseling is really, really important. And ideally, I'd love to see us have the resources in the province of Ontario so individuals could be counseled in person over multiple sessions, because the literature would support that as the most effective way of getting a good result. And high intensity counseling with more sessions and longer sessions will increase the rate of sustained abstinence compared with the low intensity counseling. But that's dollars and cents, and we all know there aren't enough dollars and cents to do everything we know would be helpful. But to reinforce the message a little bit, here are some learnings from the lung cancer screening pilot that we did. I think you were involved in the pilot, correct? Yes. And so you know that the age group was 55 to 75. They were current or ex-smokers who smoked for 20 years in total, not necessarily all continuous, and were then risk assessed. And if they had a risk of 2% or greater of developing lung cancer over the next 6 years, then they were eligible for screening. And then they were invited into the smoking cessation program that the 3 institutions could provide using an opt-out approach. And so there were these 3 sites. One used the Ottawa model for smoking cessation, which is 12 weeks of potential counseling. Now it's contacts every week, and the patient has the ability to signal whether they need the counseling or not. So it's not a person counseling them necessarily every week. And then there's follow-up at 6 months. And then they got pharmacotherapy and informational support. So a second site had set out actually to have 1 hour and a half group session, followed up by a visit or conversation with the smoking cessation champion at 3 months. That was one alternative. There are other alternatives were referral back to the primary care provider if they had training in smoking cessation, or to community pharmacists, who also, some of whom have training in smoking cessation. And a third site used 4 face-to-face sessions at baseline 3 and 8 weeks, and then at 6 months, each of them being 15 minutes in duration, and they had access to NRT. And of the patients who got to their follow-up low-dose CT scan at 1 year, you had almost 1,700 individuals, and they were asked, had they been abstinent for 30 days prior to that second scan? And the overall rate across the province was 15.5%. But I'll show in the next slide there was a range, and there was a relapse rate for those who had stopped at the time they went into the screening program of 6%, showing the challenges that people have of staying abstinent. But here he shows that the most intensive intervention, that is the Ottawa model, had a 30-day abstinence rate of 20%, whereas the intermediate and lower intensity were around 10 to 13%. So it really reinforces the message that more intensive interventions with counseling are more effective. That's consistent with the literature. So one of the things that's changing in the literature about smoking cessation is the language we're going to be encouraged to use in publications, but also I would encourage you to try and change the language you typically use in talking to individuals who use tobacco. Calling a person a smoker, and I've used the term multiple times in this talk, is just easier. But when you say that to an individual who smokes, are you a smoker? It immediately can stigmatize a lot of people and bring back feelings of shame and guilt, the fact that they do smoke. And that in itself can become a barrier to them wanting to quit or wanting to be helped to quit. So the encouragement is to use so-called person-first language and talk about people who never smoked, people who were formerly smoked, or just to say, do you use tobacco, rather than using the term smoker. It may be hard to get out of your mind. I find it hard, but it's an encouragement that I want to make to you. And then in terms of things that we have available to help you and to help the tobacco user to quit smoking, one of the first things that we created at CCO, of course, was a pamphlet. Probably reflected my age. I think paper first and think about digital second or fourth. But so there is a brochure that can be used that on quitting smoking, and it speaks to the tips about when you get cravings, what you can do about it, drinking water and distraction and so on, and other aspects about encouraging the patient, as well as the kind of things I've talked about, how it makes an impact on various therapies and what is available to treat the tobacco use addiction. But we've got modern at CCO, so we also have e-learning modules that are available both for providers and for patients. The patient module is entirely free and easily accessible through the URL. The healthcare provider one is just requires you to register. There are advantages as a provider of going to it because you can get some learning credits, either for the College of Physicians and family physicians in Canada, or you could use it for Royal College credits for a learning exercise. And as I said, the patient module does teach patients about how the smoking can affect their health, what the value is of quitting and how to go about quitting. And maybe it's something you can send to them by various forms in hard copy, by email, etc. And the smoking cessation services by Quitline have been rebranded in the province of Ontario now as Health 811. And that organization can provide a variety of services, including counseling, Quit Coach, NRT, that's apparently free. That's what they say on this website. So I take them at their word. I know they're ramping up. I don't think they're fully at capacity to handle a large load, but clearly it's a resource that we need to be considering as well. And one of the challenges is that as you saw from the recidivism rate of 6.3%, people who stop smoking, perhaps at the time of a diagnosis of cancer, get through their treatment. And I've seen this too many times as a lung oncologist, will start smoking months later after the treatment's all finished. And so it's never a one and done. And so we really need to continue to monitor the patients to see what their smoking status is. And that was the value of the tobacco use survey, which we piloted in several regional cancer centers about a year ago. Because it would then allow patients to, when they're filling out their ESAS and you're recording their symptoms, you can also capture information about the current smoking status and if they quit, what methods worked for them. And that allows you to rescreen people at 3-month intervals. And that should go into their EMR. And then if they've started smoking again, or they never stopped, or you missed them at the initial screening, you can pick them up using the tobacco use survey. So as you get over your ills with EPIC implementation, something to think about is integrating the tobacco use survey into your other activities, smoking cessation. And I know you've signed up for STOP, which is the program that the Center for Addiction and Mental Health operates in various forms, STOP on the net, STOP in family health teams, and so on. So we have STOP for regional cancer centers, and we're looking at and evaluating 2 different models, one which is tailored NRT. So they're providing free NRT, but if this is tailored to the needs of the patient, and adjusted as according, and the STOP implementer will provide that according to an assessment of the individual, and then the NRT will go out to them. Can be mailed or can be provided by the center if they have storage capacity. And then there's a standardized kit where they'll get NRT for 10 weeks at a certain fixed dose level mailed out to them from CAMH. And different centers, I think we have 7 centers in the province of Ontario that have signed up to do this, and there are various phases of being implemented, and we'll be evaluating the effectiveness of these 2 different approaches. But one thing we have heard fairly consistently from nursing staff is the availability of NRT makes the conversation about smoking cessation so much easier with the patient, because you have something you can offer instead of just sort of referring them off to a quit line, for example. So we can actually do this. So I think it will make a big difference. I'm very hopeful. So in summary, with 10 minutes for questions, hope I persuaded you that tobacco smoking is an addiction and patients need to feel supported empathetically in their quit attempts. And the messaging that you should, embroider on your pillowcase or whatever is that quitting smoking is one of the best things a cancer patient can do to help their treatment work better and reduce the side effects of treatment. And thirdly, that the best practices obviously involve both NRT and pharmacotherapy and as intensive counseling as you can provide. And then creating opportunities to re-intervene with patients about smoking cessation will also be another important support for individuals who unfortunately fall into this addiction and may easily go back to smoking. So with that, I'll stop, and I'm happy to field almost any questions. Thanks for your attention. Quiet audience. Pensive audience. Someone always asks about e-cigarettes. So if you don't ask, I'll ask myself. Yeah, well, first of all, do I need the microphone? Yes, apparently I do. So with regard to e-cigarettes, there is evidence in the literature, primarily from the UK, about e-cigarettes as a smoking cessation aid. And they can and do work for some individuals. The problem is that although they were initially created with the idea that they were a smoking cessation aid, they quickly became a very effective delivery mechanism for high doses of nicotine, and unfortunately have not been used as an aid, but is used as recreation, particularly amongst youth. And it's now recognized as just a portal to tobacco use. So instead of helping us fight the tobacco epidemic, it's actually just a fuse that's been lit that's going to create more of a tobacco epidemic. Secondly, we're just early in our understanding of the negative impacts of e-cigarettes on health. Clearly, putting an aerosol of all this particular material into your lungs can't be good. And there is lots of evidence that it produces inflammation in the airway. So I would fully expect that someone who uses an e-cigarette for any significant period of time is going to suffer from chronic bronchitis at the very least, and more likely to go on to other health problems. Health Canada has recently just commissioned CAMH to look at the health effects of e-cigarettes, and I've been recently reading literature as part of that review, and it's really quite concerning because they're finding the same components in e-cigarettes excreted in urine as we see with tobacco consumption. The same carcinogens are present. They're just in a somewhat smaller amount. So if you smoke an electronic cigarette a lot over time, say starting young and continue on thinking it's not going to be harmful to your health, we may find out in due course it's producing bladder cancer, lung cancer, etc. So the same toxins are evident in e-cigarettes. So from my point of view, in the cancer patient, I would say that using e-cigarettes as a smoking cessation aid is kind of the last resort after using what is evidence-based in terms of pharmacotherapy and counseling. But for some people, it may actually help them get off tobacco and cigarettes, where you're getting much larger dose of the products of tobacco consumption or combustion, I should say. As far as cannabis is concerned, there's very little evidence, first of all, that it causes cancer. There's one study out of Sweden that there may be an increased risk of testicular cancer in men who have used cannabis. But again, what studies are available do show irritation in the airways, hyperplasia of the bronchial epithelium, those sorts of things. We just haven't had long enough history to know whether those inflammatory changes, the hyperplasia associated in the airway, will translate into more harmful effects in individuals who use cannabis a lot in long term. The difference is that you can't smoke as much cannabis as you can smoke tobacco. Because as Ringo Starr said, you know, he got tired of waking up on the floor when you smoke too much cannabis. It knocks you out. So the volume is different. So maybe the risk is lower, but I'm just someone who believes the best thing you put in your lungs is clean air. And that's what we should counsel our patients to put in their lungs. So, does that answer your question? Please very well. Other questions? Now, are you all enthused to go out and talk to your patients about smoking cessation in an empathetic way? I see lots of nods. Thank you. And talk to your colleagues, and particularly your physician colleagues, because that halo effect, whatever you want to call it, is really powerful. And if physicians could just take the 5 or 10 seconds to reinforce the messages that others are delivering, I'm sure we would recruit many more people into cessation programs. They need that kind of additional encouragement often. And so for the physicians who aren't here, and I'm sure there are quite a few, gang up on them and tell them, you missed a great talk and you really should have been there and you should learn this message, and drill it home in their heads, you know. So anyway, thank you for your attention. I hope it's been helpful to you. Take care. Pull it out, I guess.
Thanks so much, everyone. I appreciate you coming to the first of maybe many more in-person grand rounds, and we look forward to seeing you next time. If you have any questions about the new program that we've launched at the Cancer Center, let me know. You can reach out to me and we can walk through any barriers or anything you've encountered with the new process pathway for our new smoking cessation program. Thanks so much. Have a great afternoon. That's so loud. That was great. Yeah. I know. Thank you.
Are you gonna hurt them? No, that's. Yeah, you can buy it.